Hello, thanks so much for coming out tonight for your childbirth education course. This course is designed as a combined course of doing some prep work before you come. You should have received an outline of the information that we wanted you to take a look at before you came to class tonight. If you did not receive that outline in an email, we have copies of it for you here. And you also will be able to pick up your paper book, which is the same version of what you had online for your class, but sometimes people like to follow along in the paper book as well. So what tonight is really meant for is a question and answer period. I'm going to go back over and hit the highlights of the course again. And if you have any questions, you have a facilitator in the room that will be happy to answer those questions for you. So we're going to be going through our course tonight. It's going to take about an hour and a half or so. We will be taking some breaks about every 50 minutes. And then following the course, we will be going on a tour of the birth center. My name is Leah Elliott. I'm one of the nurses that's worked here. I'm going in my 22nd year. I also am a professor of nursing at Bakersfield College. So you will hear me refer to students. Sometimes it's nursing students, sometimes it's new parents. And I am also a lactation consultant. So we may actually meet each other when you come in to deliver your baby. So really what we're talking about tonight is your journey. You are about to embark on an amazing journey. This is your journey, and I want to emphasize that. You have choices, you have options, and we're here to help support that. Obviously, everyone in the room has the same goal in mind, and that's a healthy mother and a healthy baby, and that's our goal as well. And so sometimes what we envision as our perfect journey has to change just a little bit in order to meet those goals. But I do want to say that here at Mercy Southwest, we completely support your decisions. And that's what we're here to talk about tonight, is some of those options that you have. So really the importance of childbirth education, I want to congratulate you all for being here. You're less than 0.5% of all the people that deliver at this hospital that decide to do some education beforehand. So good job. And I want to emphasize again that pregnancy and labor are normal, that most of the time you don't even need us there. We are there just to look for the abnormal and to help intervene during that time. So if you have any takeaways from this class, that's really what I want the most important one to be, is that this is a normal process for most people. So we are going to be talking about the process of labor. I really want to help you learn to trust that process. We will be looking at some options for managing labor pain and the importance of support during this process. And we will briefly touch on the topic of normal newborn. Now this is not a class where we're going to learn breathing techniques or relaxation techniques. That information is available to you in your booklet. And online, there's quite a few videos, and I highly recommend that you look at those. Even if you're planning on having an epidural or utilizing some of the other pain medication techniques early on, you want to look at those relaxation techniques, because here's the secret to childbirth. The more you relax, the faster it goes, the less it hurts. There it is. That's your secret. So these are the topics that we're going to cover throughout this course tonight. So our goals are looking at our warning signs in pregnancy, looking at some of the things that you are going to accomplish before labor begins, what the purpose of pain in labor is, the importance of movement. This is very important, and we will be discussing that at length. We're going to briefly touch on the overview of the process of labor and birth, when to come to the hospital, what interventions are available, pain management wise, what to expect as far as the hospital routine, a brief introduction to breastfeeding. Now, we also offer a breastfeeding course as well. Same format as this. You have a booklet, an online portion, and then you come to an in-person class. we're going to talk about the postpartum adaptations, some warning signs about your baby, reasons that you would want to contact your physician, and of course, answer any questions that you might have. So let's talk a little bit about this. Most women have heard all the horror stories when it comes to labor and delivery. In fact, when you found out you were pregnant and started announcing it, that's probably what all your friends and family started telling you about, is that 96-hour labor, or the most painful experience of their life. And what do we see on social media, or on media in general, is that childbirth is a painful, terrible experience. Well, I'm here to tell you it doesn't have to be that way. And part of what's happening when you're hearing these stories is you are developing fear of the process. And when you have fear, you create tension. You can't relax. And the more tension you have, the more pain you will feel. So this is why I say, if you relax, if you learn how to relax, learn how to just trust your body, trust the process, and surrender to it, then you will have less pain, and your experience, your labor will actually go faster. So relaxation, trust, and movement. This is the secret. This is why you came to class tonight. These are the 3 things I want you to learn: relaxation, trust the process, and movement. These are your key components to labor. So let's talk about getting prepared. Some of the things that you need to accomplish before you come to the hospital is you need to pre-register. When you go on your tour tonight, you'll be shown where the admissions office is. And if you have not done so already, you'll need to pick up some paperwork there and complete it and go down and get the admission process done. You certainly don't want to have that process not done when it's time for you to come into labor. The second thing you need to do is choose your pediatrician. If you have private insurance, you're going to want to talk to your insurance company and find out which physicians are on your plan, because we do have an in-house, what we call a city call physician. But if you have private insurance and they happen not to be a provider of that insurance, you could actually have a bill at the end of that. So you certainly want to choose a provider that your insurance company is going to cover. And as far as asking around, asking for friends, maybe talking about it in mothers groups, that's where you're going to get your recommendations. The hospital cannot actually recommend a pediatrician for you. And then educate yourself. That's what you're doing. You are learning about your options, learning about what it is that you're hoping for on your perfect day, and making decisions that are right for you. Remember, I told you this is your story. You get to write this story, and you have to decide what works for you. You're going to see lots of information out there, especially on social media, about all these different things that are available, processes that are available for you to do. Please make sure that you're doing good research. Google is not always an excellent source, and Facebook is not an excellent source. Even your news channels are not completely accurate all the time. So if you have questions about things that are offered to you, please ask one of your nurses or your physician. We'll be glad to give you the research and the evidence surrounding those practices. There are some things that are offered out in the community right now that are actually unsafe, but they are being advertised as being completely safe, and it's an unfortunate circumstance. So make sure that you're really doing your research from legitimate sources. And then the last thing you need to do is get your car seat in the car. We will check to make sure that you have a car seat before you go home, but we cannot make sure it's in the car correctly. So you can call your sheriff's station, call your local fire station, and they can help you confirm that your car seat is in your car correctly, but that's not something that the hospital can do for you. So there's your homework. Okay, and again, here are some trusted sources. You might want to jot these down. If you're looking for information about procedures, interventions, things that you might be offered to purchase, things that you might be offered to do after the delivery, be sure that you're looking at good sources. Lamaze.com, Enjoy, that is the company that has created the booklet and the childbirth class that you're currently taking. Spinningbabies.com, physical therapist that has created has some evidence-based research that supports her different positioning techniques. Babycenter.com, they have good information there, and ICEA, International Childbirth Education Association. So look at those trusted resources when you're looking for information. Another really fantastic resource would be evidencebasedbirth.com. So in your booklet on page 32, you have some information about a birth plan, and we do recommend that you write it down. If you don't bring it in a paper form, that's perfectly okay. You can just let your admission nurse know what it is that you're hoping for your delivery. There are quite a few things that we see on birth plans that we that are already offered by the hospital. For instance, we do delayed cord clamping. That isn't something that's special that you have to offer. We will not offer any formula or pacifiers in our hospital because we follow the baby friendly initiative. And so if that's something, sometimes you'll see that as an option on the birth plan. So make sure that when you put things down on your birth plan, you want to make sure that they're educated, which is one of the things you're doing right now, and that it's not things that we would normally offer. So when you got the email to this course, you have my email, actually, leahelliott2@dignityhealth.org, and you have an option if you want to run something by me, or you have questions after the course, you're welcome to go ahead and send me an email. And it's leah.elliott2@dignityhealth.org. So as far as your birth plan goes, I always recommend that you have plan A, B, and C. A is your perfect day. Everything goes according to plan. It's absolutely everything that you had dreamed of. B is you'd be willing to give up a few of these things in order to meet our goal, which is a healthy mom and a healthy baby. And then C is nothing really went according to plan, but in the end, we still get our healthy mom and our healthy baby. So if you have these ideas in your head and you've already thought them through, then you don't have to go through such disappointment if your plan A doesn't work out. Because in the end, if we have a healthy mom and a healthy baby, then we all have won. Things to pack. This is going to be on page 24 of your booklet. You definitely want to bring some pillows for your support person. We do have pillows available for our patients, but they are a hot commodity in our unit. And so if you have extra pillows that you can bring, that would be very helpful. If you have a breastfeeding pillow, go ahead and bring it to the hospital. It's a good tool that you can use when you are working with positioning that baby. You want your car seat already installed in the car. You can bring music that is soothing to you. We do have some relaxation music and a relaxation channel on our television, and we will introduce you to that when you get admitted. But you're welcome to bring whatever music you would like to. I see a lot of those speakers that come, the little Wi-Fi speakers, and so then you can bring whatever music is comforting and soothing to you. We do have Wi-Fi available. It's free. You do have to accept the terms when you come on. It's guest. There is no password. You can just sign on to it. And then food for your support person. We provide all the meals needed for the patient, but if there's something special that she wants, or if you would like to have food for your support person, you will need to bring it, and you will have to have some way of keeping it cold. We unfortunately cannot put it in our refrigerator. It's one of the laws that is of the JCO creates that law that only patient food can be stored in the refrigerator. So, but you're welcome to bring an ice chest. There's also plenty of eateries up and down the road. You can have DoorDash or Uber Eats bring food into the hospital as well. And when you go on your tour later tonight, we're going to be showing you the entrances that you will be coming in. And that is where you would send any delivery. Okay, warning signs in labor. These are warning signs that you would want to contact your physician immediately. This is page 7 and 9. So some of the things that we would want to contact your doctor, and if your doctor's not open, that means you would also want to come into the hospital. These are warning signs that cannot wait until your next appointment. If you have signs of preterm labor, more than 4 contractions in an hour, feeling a crampy backache that's coming and going on a regular basis, you would want to come in and be seen. If you are preterm and are starting to have signs of labor, sometimes we can figure out why that's going on. And sometimes we have medications that we can actually delay it. So the sooner you come in, the better when you start having those preterm labor contractions. Vaginal bleeding, as you get closer to delivery, you might wipe and see a little smear of blood. That's normal. We aren't upset about that. Bright red blood running down your leg is a medical emergency, and you need to come into the hospital as soon as possible. Abdominal pain, especially in the area right up underneath your ribs on the right side where your liver is, you would want to come in and let us take a look at that. If you have a fever over 100.4 Fahrenheit, you want to come in and let us figure out why you have a fever and hopefully try to fix that and decrease that fever, because your baby is about a temperature higher than you are, and we don't want your baby to be overheated. A headache that doesn't go away with Tylenol, urinary discomfort as in cramping in your back or aching after you urinate could be a sign of an infection. You would want to have that looked at right away. And then decreased fetal movement. You should be paying attention to your baby's movements at least once a day. And if you don't get 10 movements in an hour, you're going to want to come in and be seen. We don't want you to wait 2 or 3 days without feeling your baby move before you come to us. The first thing that happens when your baby becomes stressed in the womb is it slows all of its movement down. So we can intervene early on if you come right in. So decreased fetal movement would be a reason to come directly into the birth center. And here's some information about tracking your baby's kit counts. What I was just mentioning about fetal movement. So after the 28th week, you should be spending at least a little small portion of every day paying attention to your baby. You will time how long it takes to get 10 movements. That's kicks, punches, swooshes, and body movements. Usually you'll have 10 movements within 2 hours, but if you have less than that, you want to come in and again, let us give a little look and see how things are going. Okay, now we're going to move into the process of labor and birth. And remember, this is just an overview. If you have specific questions, you can feel free to stop this video and your educator in the room will be able to answer those questions. So this is what we see on media. In fact, you probably have seen all of these. This is what media tells us that labor and birth looks like, how women act. And I'm here to tell you this is actually not the norm. This is rare. Is it hard? Yes, it is. Is it painful? Yes, it is. It's a process. It's a process that happens over a day or two. For a first-time mom, we expect her labor to last somewhere between 12 and 24 hours. A second-time mom, it's a little bit less than that. But it doesn't start off as really extremely strong contractions. It starts off very slow. You might have a contraction and then lasts 30 seconds, and then in another 20 or 30 minutes, you might have another one. And so it's a slow process in the beginning. And we're going to talk about the stages and phases here in just a minute. But this is what you've been taught, and this is what it can look like. Lots of support. It's a very loving time. Partners usually feel very close to each other. And partners in the room, this is where your knowledge of your partner is so important. Knowing what she likes, how she likes to be touched, what is comforting to her, and just being present is a huge comfort to women. And that's really what your role is. Yes, it can be surprising, it can be shocking, and it can be joyful to deliver a baby. So forget about everything that everyone else has told you about having a baby and just experience your own experience the way it comes. If you can put aside all those thoughts and preconceived ideas you have and just enjoy your journey, you will be better off for it. So I like to describe here the discomforts of pregnancy. So some of the reasons you're feeling the way you are is because before you were pregnant, you see your liver has all of this room. Your lungs have all of this room. Look at your intestines. They're taking up your entire abdomen. Your bladder has all the room in the world. Well, now that you're growing this baby in the front here, you have your intestines are squeezed, your stomach is smaller, your liver is compressed, your lungs are compressed, and look at that poor little bladder. That's why you have to go to the restroom so often. Speaking of that, as this video is going on, your educator in the room will stop at certain points so that you will have an opportunity to go and empty your bladder. So where does the pain of labor come from? The thinning and dilation of the cervix, so the thinning and opening of the cervix, is part of where that pain comes from. You can kind of think of the uterus as like a turtleneck sweater that has to open and thin and stretch over your baby's head in order for your baby to come out. Another point that causes pain in labor is the pressure of the baby's head. As the baby's head moves down into the pelvis, there's going to be increased pressure. Lactic acid buildup from your muscle. Your uterus is a muscle and it's working very hard and making those contractions happen, and that can cause lactic acid buildup. The size and the position of the baby definitely can increase your pain in labor. And this is where movement comes in. Movement is so important to help that baby get into the optimal position. The stretching of the vagina and perineum as the baby is actually coming out, and then your personal beliefs and how you've been culturally conditioned to respond to pain. Those will also be factors in how you express your pain in labor. So pre-labor, I like to call this pre-labor rather than false labor. Your book refers to it, I believe, as false contractions or false labor. These are those Braxton Hicks contractions that start happening sometime in the second trimester. And a lot of women say it feels like the baby's kind of balling up on one side. Well, really, that's your uterus starting to do some pre-labor contractions, some practice contractions. They're often painless. You know they're there, but they're not painful. They're irregular, usually mild, and the purpose is to get that cervix ready for labor. Again, that cervix has to thin, and then it has to open before the baby can come. So in a first-time mom, we see it really has to thin almost completely before it will start to open. And these Braxton Hicks contractions are what help you get that process going. So when you're feeling those little runs of Braxton Hicks, be thankful. That's all work that is being done beforehand. So when we're talking about effacement, we are looking at the thinning of this cervix. So here's the cervix, the bottom of the uterus, and it starts off very thick, about like your earlobe, and then becomes very thin. We call that 100% effaced, about like the skin in between your thumb and your pointer finger. So in the beginning, we call that 0%. When it's completely effaced or completely thinned out, we call that 100%. So you'll hear us talking in these terms when you come in and you start having your exams. So effacement is thinning of the cervix. Dilation is opening of the cervix. So it starts off almost closed. It's about 1 centimeter. We measure with centimeters, and when we're doing an exam, we are using our fingers to decipher how many centimeters open that cervix is. So it starts off very thick and closed and becomes very thin and open, and then this is able to slide back over as the baby's head comes down, and that is how your baby comes out to greet you, comes out to meet the world. So the process of labor is opening and thinning or dilating and effacing that cervix. And so we start off at 1 centimeter and then go to 10 centimeters. This is not to scale. The next thing that has to happen is your baby has to move down in the pelvis. So as the baby starts to move down, we measure that in what we call station. So our negative numbers means the baby is still very high in the pelvis, and our positive numbers means the baby is coming down lower and moving towards the outlet of the pelvis. So the most important thing here is your maternal movement is going to help this baby get into the most optimal position. So what I mean by that is one of the theories of why we have pain in labor is that it will encourage the mother to move. Most people will rock or sway or kind of dance, lean over their partner, dancing back and forth when they're having these contractions. And the idea is to help the baby move down into the pelvis and get into the most optimal position so that the head fits easiest through the pelvis. So the attendant in the room, the educator in the room, is going to show you with the model how that baby actually comes through. The baby should be facing down. That's the best position. That's where the widest part of the head fits through the widest part of the pelvis in the easiest fashion. And sometimes our babies will get twisted and turned around where they're actually facing up. We call that an OP, or occiput posterior position. And one of the things you will notice if your baby's in that position, you'll be having a lot of back pain. And so again, maternal movement, staying out of that bed as much as possible, using all different sorts of positions while in labor, will help this baby get into the most optimal position for delivery, and that will decrease your labor time. So now we're going to be talking about, am I really in labor? How do you know? Well, we have 3 phases. We have early labor, active labor, and transition. These 3 phases are very subjective. They can go anywhere from 8 to 24 hours in that early labor. That's when we're having those mild contractions. They may be 5 to 20 minutes apart, lasting about 30, 40 seconds. And then we move into a more active stage. That's when our cervix is 6 to 8 centimeters open. This phase can last anywhere from 2 to 6 hours. And it is when you're feeling those contractions about every 3 to 5 minutes. They're lasting about a minute. You usually have to concentrate a little bit more on getting through those contractions. And then our transition is where we have our most intense contractions. They're not really any stronger than they were in the active phase, but they come a little bit closer together, so you get less of a break. They're 2 to 3 minutes apart. That's that last little bit of cervix that has to melt away. And this can last anywhere from half an hour to 3 hours. So again, for a first-time mom, we're looking at anywhere from 12 to 24 hours. For a second-time mom, a little bit of that time can come off. So our process is going to be a couple of days long in order to get this baby here safely. And if you are coming in for an induction and your cervix is not ready for labor, what we call ripe, you can add a couple of days to that process, because then we're asking your body to do what it isn't quite ready to do and what it would have done over a couple of weeks period of time. So my whole point of showing you this slide is that you need to be patient. This is a process. It took 9 months to grow this baby. It's going to take a couple of days for this baby to be born. So when we are timing contractions, when we talk about frequency, we time them from the beginning of one contraction to the beginning of the next. And when we're talking about duration, which is the length of the contraction, it's from the beginning of one contraction to the end of that same contraction. So why is this important? Well, this can help you decide what stage of labor you're in. And we highly encourage, unless you have been told otherwise by your physician, that if you're in that early phase where your contractions are every 5 to 10 to 15 minutes, they're lasting 30 to 40 seconds, and you are not having to work very hard to get through them, that early phase, you're going to be so much more comfortable at home. You do not need to come to the hospital the minute you feel your first contraction. Again, that's if you're low risk and unless your physician has told you otherwise. You can spend your early labor at home. There's so many things you can do at home. You can get into your bathtub if your water is not broken. You can certainly get into your shower. You can sleep in your own bed. You can walk around your own yard or neighborhood. You can eat what you want. You can spend time resting or napping in your favorite rocking chair. There's lots of things you can do in that early labor that will help you progress. once you get into the more active phase, that's when you want to come into the hospital and utilize the resources that you have there. So true labor versus pre-labor. In your book, you have lots of different, lots of information about how do you know true labor versus pre-labor. And here's the truth, is that true labor dilates the cervix, so opens it, thins that cervix, so effaces it, and that baby moves down. The contractions will get longer and closer and more intense. Pre-labor or early labor, the cervix is not dilating. Those contractions are mild and eventually may even go away. So in the couple of weeks leading up to labor, you actually may have a couple of times where you think, is this it? And you'll have contractions and they'll be getting a little more regular, and then they'll just kind of fade away. When you start having, especially as we move into the warmer months, when you start having those pre-labor contractions, make sure that you're well hydrated. A well-hydrated uterus will work much more efficiently than a dehydrated uterus, because remember, it's a muscle. And so you want to make sure that you are drinking lots of fluid during that time, eating lightly, and move, lots of movement. So some of the things that may happen in your pre-labor events is your bag of water may break. If that happens, it could either be with a gush or it could be with a small trickle. The only way for us to tell if your membranes have ruptured is for you to come into the hospital. There's no way for us to know that it has happened over the phone. So if you think your water is broken, that would be a reason that you would want to come in and visit. And I have another slide here coming up that will define when you should come to the hospital. You also may notice that there's an increased mucus-like discharge as we get closer to labor, even as those pre-labor contractions start. And that's a little mucus plug that's been sitting up around the cervix, keeping bacteria from getting to your baby. So if you think your water has broken, what we typically tell women, if you're not sure, go ahead and put a pad on. If it continues to be wet, you should come in and let us take a look at that. But it may just be that increased mucus. And if you put a pad on and you notice that there is no more leaking and that pad has stayed fairly dry for a couple of hours, then you can feel pretty confident that your water has not broken. So having said that, if you think again, if you're suspicious your water is broken, you want to come in and be checked. And if you're still in that early labor phase, you can go back home. And as long as we follow a few precautions, nothing in the vagina, no intercourse, and no tub baths, then you could be home for a while and then come back in when your more active phase of labor has started. If you think your water has broken, you'll want to keep note of color, odor, amount, and time. Your book likes to refer to that as coat. That's the mnemonic they give you. Here in the Valley, we don't really have much use for a coat. So I like to remember tacos. It stands for the same thing: time, amount, color, odor. Either way you remember it, these are the questions we're going to ask you if you tell us that you think your water has broken. So when should you go to the hospital? The most important thing is you want to listen to your inner voice. When you think you should go, you should go. Listen to your body. If you are comfortable at home and you're utilizing the tools in your toolbox for your early labor and you don't have any risk factors, then you can stay home. You don't have to come to us, like I said before, in that early phase. But if your water breaks or continues to leak, your contractions are somewhere between 4 to 5 minutes apart. That's from the beginning of one to the beginning of the next, lasting a minute. You can't walk or talk through them. That would be a time that you could start thinking about heading this direction. If your healthcare provider recommends that you come in as soon as possible, maybe you need antibiotics in labor, or your mother has a history of fast labors, or there's something else going on with you that would warrant you needing to be in the hospital for closer evaluation, then of course you would come then. Or you just feel like you need the resources that we have to offer you. If you come to the hospital and you're still in that early phase, we're going to give you the opportunity to walk around, possibly even discharge and go back home until that more active labor phase begins. Sometimes women are a little frustrated with that, but it is actually a favor to you. The less intervention we do, especially in that early phase, the less chance of a cesarean section you will have. So here's a little mnemonic from Lamaze.org, and this is your early labor comfort measures. Resting and relaxing, drinking plenty of fluids, eating what appeals to you, going for a short walk. Nobody needs to do a marathon, but a short walk is a great way to get that, to keep that movement going and help that baby find the best position. Using your birth ball or peanut ball if you have one at home. Really using your relaxation techniques, using a warm pad or an ice pack or a rice pack on your lower back, reading a good book, watching a show. Some people have recommended that you save some networks, something that Netflix that you want to binge watch and use it for early labor. That's a good tool. Or you could bake a cake from scratch. That's a good early labor tool. Asking your doula or your partner for a gentle massage. All of these ideas will help keep you calm and help that early phase of labor be very productive. Remember, relax and surrender are your tools. So early labor, again, is that dilation all the way up to 6 centimeters. Mom needs to rest, stay hydrated. She may be anxious, eager, excited, or mindful during this time, probably very talkative. This is when she's starting to send out messages to her support team. I think it's happening. Today might be the day. And you can start really getting excited about meeting your baby. Your active labor is when your mom is going to be focusing more on those contractions. She's going to be working a little harder. She may be very vocal. Partners know this. Sometimes women need to say things like, I don't know how much longer I can do this, or this is really hard work, but they don't need to be rescued from that. They just need to vocalize that. If you're planning on having an unmedicated birth, this would be a great time to utilize nitrous. I'll talk more about nitrous in a few minutes. If you're planning on having an epidural, this would be the time that you would get your epidural. Once you've gotten the epidural, it's going to become the nurse's responsibility to move you, and it's going to be on a very regular basis, every 20 minutes or so. So don't be frustrated just as you get comfortable if we're coming back in the room and helping you to move into different positions, because again, that movement is key in getting the baby into the best position. Lots of research has been done about epidurals and C-sections, and what they have found is epidurals do not cause increased C-sections, but epidurals can contribute to malposition of babies, and that can increase C-sections. So we want to give you every opportunity to have a vaginal delivery. And then that transition time, that 8 to 10 centimeters, mom needs lots of encouragement during this time, not a lot of questions. At this point, we're going to let her move inward and really focus on what her body is doing. Again, if you can relax and surrender to the process, this part will go faster and will be less intense than if you are upset and tense during this time. So there are 4 stages of labor. What we were talking about just now were those phases of the first stage, but our 4 stages of labor is dilation and effacement of our cervix. And then our second stage is when your cervix is completely dilated, completely open, and now we're pushing the baby out. Our third stage is from the birth of the baby until the placenta comes. And then the 4th stage is recovery time after the birth of your placenta. So again, our first stage, we've talked a lot about that. That's that dilation and effacement of the cervix. That's what we call labor. And then the second stage, pushing that baby out. If you are unmedicated, you will have an overwhelming urge to push this baby out as soon as your cervix is fully dilated. If you have an epidural, we might utilize something called passive descent or laboring down. And this is where we will let your body continue doing its work and we won't actively start pushing until you start to feel continuous pressure. Your labor nurse is going to guide you during this time. And then once the baby is born, we will let the cord stop pulsing, and then it will be clamped and cut, and the baby will be skin to skin with you during that time. And then our fourth stage is recovery. So during this time, we're going to be watching your vital signs very closely. We'll be watching your bleeding very closely, and you'll be getting to know your baby and bond with your baby and have your first feeding. So factors that definitely affect labor: maternal movement or lack thereof, the position of the baby's head, the size of the baby, the size and shape of the mother's pelvis. We cannot change that, but that definitely does affect labor. Mother's emotional and physical state, how well she feels supported, how comfortable she is, how bonded she is to her caregivers, and how much trust she has in their care will definitely affect how labor goes. If you're just not connecting with your nurse, say something, ask to speak to the charge nurse, and get an assignment change so that you can have the experience that you're looking for. Effectiveness of the contractions definitely can affect labor. How well supported the patient feels by her birth partner and the team that she's chosen to be around her. Make sure when you're inviting people into your delivery room, you're not doing it out of obligation, but you're choosing the people that are going to be the most supportive to you at that time. And then any medications or anesthesia that have been administered will affect your labor. I already mentioned this, but this is just a visualization again of back labor and why we get it. Our baby should be facing down. This is how we would like this baby to come out. This is the mother's back, and we would like the baby to come out this direction because you can see the head fits the best through the pelvis. When we have a baby in this position, or some other version of this position, you can see the widest part of the head is trying to fit through the most narrow part of the pelvis. And how do we fix this? How do we keep babies from getting in this position? And how do we get them moved out of this position if they've gotten there? Movement. That's right. You got it. We got to get those moms up and moving. That is the most important factor. So here are some coping ideas. You can use music, you can use moving and changing positions, a focal point, something to focus on while you're having those contractions, a calm, supportive environment. Partners, let's look at the lighting. Let's look at how she's feeling about the room. Put on some of that relaxing music. Using some deep controlled breathing. Again, your book has some great videos that will show you some of those breathing techniques. The most commonly used one is just a deep breath in through the nose and then out through the mouth. Slow, deep breathing will help relax. In fact, we should be using that kind of breathing throughout our regular lives. Massage and counter pressure, that's where you come in, partners. You can utilize the shower or bath. We do have showers available in the birth center. You'll want to make sure that you have spoken to your provider previous to going into labor about wanting to utilize this. And then heat. Heat can also be a good source of comfort. Here are some different breathing patterns. We're not going to utilize the one that she's using. This is hyperventilation, and we certainly, it's not a good technique, but with our breathing patterns, again, that deep breath in through your nose, out through your mouth, slow, deep breath, concentrating on relaxing, releasing, and surrendering is your best bet and one of your biggest tools in your toolbox for relaxation. Here's how we're used to seeing women labor: flat on their back, in bed, flat on their back. And this is how I want to see you laboring, utilizing those different positions, out of that bed as much as possible. Even if you require continuous fetal monitoring, those cords are fairly long, about 5 feet long. So you can still be on that continuous monitoring. We can use a belly band, which is a way to hold those monitors on a little more securely. And then you can be up and out of that bed utilizing movement. Ask your nurse. She's got lots of ideas and position techniques for you. We currently do not have birth balls in the unit. If you want to bring a birth ball or an exercise ball with you, you certainly can. It will need to be blown up when you come in, but we do have peanut balls that can also be used in labor, and you just need to ask your nurse and we'll make sure that you get one into your room. So again, we have our stages of labor: early, active, and transition, and we've talked a lot about those tonight. So don't think we have to spend any more time on this. If you have any questions, this would be a great time to stop that video, maybe take a break, run to the bathroom, and ask your educator if you have any questions about anything we've covered so far. Okay, so here we are back again. We're just going to cover very quickly. Our early labor mom is super excited, eager. She's very social at this point. That early labor is 0 to 6 centimeters. That cervix is starting to thin and open and dilate. Our active labor mom is not nearly as social. She's very involved in the work of labor. You will want to be in the hospital at this point when you're in that more active stage. This is when you can utilize the support that we have, and we want to be monitoring your baby at this point. Up until active labor, being home if you're low risk is going to be the best option for you. So during active labor, it's our 6 to 8 centimeters. Cervix is thinned out, starting to open, baby's moving down into that pelvis. And then our transition, mom's focus is very inward. She's working very hard. She's concentrating. If you were planning on getting an epidural, you certainly would want to have one by this point. And remember, these are labor epidurals, not delivery epidurals. So really the focus is of labor. This is that last few centimeters of the cervix, 8 centimeters to 10 centimeters. That cervix is completely thinned out now and is opening to its widest point so that, like a turtleneck sweater, it can slip over the baby's head as we start to feel the pressure of wanting to push this baby out. And then pushing is our second stage. This can take, for a first-time mom, anywhere from, if she's unmedicated, up to 3 hours. If she is medicated, we actually give her up to 4. So this is a process. It's kind of a 3 steps forward, 2 steps back process. Whoever has been elected to be in the room for the delivery, we recommend 3 to 4 people for the actual delivery. Those are the people that are going to be there during the pushing stage. We don't have the door open and have a lot of family members coming in and out at this point because we want to give the mom the privacy, and she's working very hard. And so we want to make sure that we're supporting her in that. Another thing I will say here is sometimes family members that have not been elected to be part of the delivery room think that they'll just stand out in the hallway so that they can kind of hear what's going on through the door. And unfortunately, we can't allow them to do that. At our nurses' desk, we have nurses that are talking to physicians about their patients, and lots of patient information is being kind of passed around. And so in order to protect everyone's privacy, we ask that everyone is either in the room with the patient at her discretion or in the waiting rooms. We can't have people out in the hallways. And then the third stage is when the placenta comes. This is when the baby is skin to skin with mom, and the placenta will be released, and the uterus will start to clamp down to cover up the area where the placenta once was. This is your recovery time. And here, our skin-to-skin time with our baby, we call it the golden hour, but really it is as long as it takes for this baby to have their first feeding. If you want to do some research at home, go home and look up the infant microbiome. We have learned so much about this in the past 5 to 7 years, and this is really where we are building this baby's immune system. And part of the bacteria that starts to build this baby's immune system comes from this skin to skin time. So it's very important that mom get this skin to skin time if everyone is stable. Super important that the partner also participate in skin to skin at some point, because we're building this baby's immune system, and it comes from the bacteria that is for the people that are surrounding this in this baby's immediate environment. So skin to skin, very important. It does lots of things for moms, lots of things for baby. And as excited as your family is going to be to meet this new baby, this is very important. And I would highly recommend that you delay passing this baby around to all of your visitors until you've had appropriate skin to skin time and initiated that first feeding. Some of the things that our skin to skin does is it normalizes temperature and normalizes heart rate for both mom and baby, blood sugar, and allows babies to exclusively breastfeed longer, especially if we leave that skin to skin uninterrupted until they have their first feeding. So as long as that baby is stable, we will be leaving the baby skin to skin until the first feeding has been initiated. And sometimes that can take a little bit depending on how long the labor was and what medications were utilized in labor. If you're not planning to if you're not planning to breastfeed and you're only planning to bottle feed, we still recommend that that first feeding happen while skin to skin with your baby. Now we're going to move on into our medical interventions. And interventions are, some of the ones that we utilize are medication used to induce labor. We'll talk about induction of labor. Medication used for pain relief. Artificial rupture of membranes, so breaking of that water artificially, and continuous electronic fetal heart rate monitoring. Interventions can always cause side effects and lead to further interventions. So anytime an intervention is offered to you, I want you to use your brain. This is your acronym to remember that you're going to ask, what is the benefit of this intervention? How is it going to help my labor or help me or help my baby? What are the risks involved with this intervention? How will this affect my labor, affect my baby, or affect me? Are there any alternatives? What does my intuition say? And can I have some time to think about this and talk about it with my family? So anytime you're offered an intervention, you want to use your brain. So fetal monitoring is a window into the womb. This allows a labor and delivery nurse and a care provider to see what's going on with your baby. It's a very good indicator of how well your baby is tolerating labor. But if you're low risk, we don't have to do it continuously. Continuous fetal monitoring actually leads to increased interventions. In fact, in the last 30 years, we have increased our amount of fetal monitoring, but we have not decreased the infant morbidity and mortality because of the fetal monitoring. So what we know is it is a fantastic tool, but it needs to be utilized correctly. So have a conversation with your physician about the possibility of intermittent fetal monitoring or even a Wi-Fi fetal monitoring. We do at this point have one fetal monitor that can be utilized through the Wi-Fi, which means that you have a lot more freedom of movement. So have this conversation with your physician before you come into the hospital. This is what the fetal monitor looks like. This top monitor will pick up contractions. This bottom monitor will be looking for your baby's heart rate. And so as the baby moves and you move, these monitors may have to be adjusted. And that's our role as the labor nurse to come in and do that for you. This is a picture of the Monica, which is the Wi-Fi monitor. Looks just a little bit different. And again, it provides freedom of movement. So labor induction, there's a couple of different reasons that we would do it. Some of the reasons might be medical, and a medical reason for induction would be high blood pressure, maternal diabetes, a post-dates pregnancy, that's after 41 weeks and 1 day, small for dates pregnancy, meaning the baby is not growing at the rate that we would expect, or the membranes have ruptured and we don't see any signs of labor. So these are considered medical reasons for induction, and sometimes these will even happen before the 39th week. We know that for a medical reason for induction, that this baby is most likely going to be better on the outside than on the inside, and that the risks of induction warrant the starting of that induction. So other reasons that sometimes people are induced are not medical. If it's any reason other than what's listed on this list, it may be what we call an elective induction. And those are inductions where we've just decided that we want to start the process. There's not a medical indication. Many hospitals are actually moving away from elective inductions because we have found there are risks to induction. And one of the highest risks to induction is primary cesarean section. So you want to have a good conversation with your physician about your reasons for induction. As we looked at that picture earlier of some of the common discomforts, it's not uncommon for women to start feeling really overwhelmed with being pregnant, feeling very tired. It's difficult to sleep, a full night's sleep. I think this is nature's way of getting us ready to be up and ready to be with our baby. But it is not uncommon to feel uncomfortable. That may not be a good enough reason to put forth the risks of elective induction. So again, I want you to do your research. If you have questions, we will be glad to answer them. And any elective induction won't happen until after the 39th week. And if once you have decided that you want that process, I want to talk a little bit about how it works on the birth center. Your physician will call over and ask to have you put on the induction book. And then every day, a physician will look at that list and decide who is medical and who is elective. And of course, the medical indications will come in before the elective procedures. So it may mean that if you were scheduled on a Tuesday, we may not have the availability to bring you in until later in that week, maybe even as much as Friday or Saturday. So know that it's not an actual appointment that you're getting. It's just you're on the books, and then it will be decided based on medical necessity. Artificial rupture of membranes is something that has been done for a long time. And what we know is that when we rupture those membranes, it can release some of those prostaglandins that sometimes can encourage labor to get going. Early artificial rupture of membranes has been shown in the evidence to increase malposition of babies. So again, if it's offered to you, you want to have a conversation with your physician. What are my benefits? What are my risks? What are my alternatives? What does my gut say? And do I have some time to think about that? Your educator in the room is going to show you what an amni hook looks like. This picture is a little bit misleading. It looks very harsh and vicious. And so I've actually have an amni hook in the room for you to see what it looks like so that you won't be frightened of the procedure. And then we have pain relief options. So we have a couple of ways that we can help you with pain relief. We have systemic medications, narcotics that go into your IV, and they will help reduce your pain in that they don't make it go away. They just help you relax, help you get through it. It's like, I like to say, like drinking a margarita, just helping you to relax a little bit. Fentanyl is the most commonly prescribed medication. You do have a maximum amount of 6 doses that you can have through your entire labor. So if your plan is to use intravenous medications to get you over the hump or just through that rough patch, know that you only have 6 doses for the entire labor, and your baby has to be tolerating it well in order for us to continue giving that medication. The next thing we have are regional anesthetics, which is your epidural or spinal. Epidurals are typically used for labor, and spinals are used for cesarean. If you happen to already have an epidural in place and need to go for a cesarean delivery, we can utilize the same space. It doesn't have to, the procedure doesn't have to be done again. There's a really good video in your book and on your online app that shows an epidural. There's also a good video on babycenter.com and shows actual procedure. I urge you to watch that if that is the pain relief method that you are looking forward to. And then we're excited to talk about nitrous. We're one of the few hospitals that actually have nitrous, and it's a technique that's been used for over 100 years in Europe, and we've just brought it to America It's just becoming more popular. So nitrous is laughing gas. Some of you may have used it when you go to the dentist. And it is one of those tools that, again, just helps you get through the process. It does not take the pain away, but it helps you to relax. And remember, relaxation is one of your keys. And so this medication is used by the mother, and the mother's body actually processes it, and it does not affect the fetus. And it's one of the few tools that we have that actually does not affect the fetus that can help mom relax. So talk to your physician about nitrous, and if that is something that you're interested in, let your labor nurse know as soon as possible when you come in, because there's a little bit of a process to get these things in place. So here is a little picture of where the epidural goes. And I like to show you this picture because there's a lot of myths surrounding the epidural. Epidurals are placed by either an anesthesiologist or a nurse anesthetist. And it is a procedure that is done very similar to your IV procedure when your IV was placed. This needle is placed into the back, and a small catheter is thread into this epidural space. It does not go into the spinal cord. A lot of myths surrounding this is that it can cause permanent backache. And I want to point out that when you have this procedure done, it does go through these vertebrae. It has to go through the vertebrae into this space, but the nerve roots are actually over here. So nerve damage does not happen because these nerve roots are on this side. A lot of people have heard that epidurals can cause backache, but it's actually the process of pregnancy that can cause prolonged backache and not epidurals. The spinal goes a little bit deeper, and the medication causes a little bit of a deeper block. Again, those spinals are utilized for typically for surgery. And then moving into cesarean birth, some of the reasons that we have a cesarean birth is failure to progress in labor. And one of our biggest reasons for failure to progress is a failed induction or malposition of the baby. The baby's not in a good position to put pressure on the cervix and allow it to open. Sometimes irregular fetal heart rate, positions of the baby being breech or bottom first, or if you've had a previous cesarean birth, might be a reason for an elective repeat cesarean. Other reasons could include placenta and cord problems, or babies' heads that are just too large to fit through the mom's pelvis. Cesarean birth is still birth, and we want to make sure that you understand if that is the direction we go, that's when we have in our plan C that we're still looking for a healthy mom and a healthy baby. And this is what everyone has decided needs to happen in order to have that healthy mom and healthy baby. Here is a picture of a mom doing skin to skin right after a cesarean birth. There are a couple of different kinds of closures that can happen, stitches, steri-strips, or staples. That is provider preference. And if you have something specific in mind, you would want to have that conversation with your provider. The average length of stay for moms that have a vaginal birth is 24 hours after birth. The average length of stay for moms that undergo a cesarean birth, it is 48 hours after birth. So now would be a great time to stop the video, have any questions that you might have answered by your educator in the room, take a bathroom break, and come on back and we'll talk about your new baby. So here we are, new beginning, everything is different, many changes are happening both physically and emotionally. I want to encourage you, enjoy this special time. As hard as it is to be recovering from your physical ordeal, you have a newborn for 28 days. It goes by so fast. In fact, all of childhood goes by so fast. And you won't really truly believe that statement until you've experienced it yourself. But rest and recuperate and recover and bond and get to know this baby and really enjoy this time frame. If you were to ask any mother, she will tell you she would like to go back and do that first month again because she had no idea how fast it was going to go, and she wouldn't want to wish away a day of it. Newborns are certainly precious. And for you new fathers or partners, making sure that you're bonding with this baby, this is when it's really going to become real for you. Spending time with this baby on the outside, snuggling skin to skin, doing things like burping and changing diapers and bathing that baby, taking the baby for a walk. These are all ways that you can participate. Sometimes partners and fathers of breastfeeding mothers feel like they don't have anything that they can offer the baby, but there's plenty of things you can offer the baby. Little scenario I'd like to tell you about is when babies get upset, mothers are hardwired to be upset as well. When they hear that baby crying, there's something in their brain that says, you must fix this. This is your responsibility. But for fathers, it's not like nails on a chalkboard. Of course, we don't like to hear babies cry, but you don't have the intrinsic internal turmoil that a new mother will have. So if you see that your baby is upset and your partner is upset, take the baby, walk away, allow the baby to calm down, allow the mother to calm down, and then bring them back together, because they can feed off of each other, and that can become worse and worse and worse. Okay, and a couple of self-care hints. Now is not the time to start a major household project. You certainly want to have simple meals, a flexible meal time. If you're the type of woman that never has a spot of dirt on her floor and always has the laundry done and there are never dirty dishes, we're going to give that up for just a little while. You'll get back to being that type of woman again. But for now, the most important thing is that you're taking care of yourself, taking care of your baby, spending time with your baby. If people ask you what they need, what they can do to help you, let them help you. If they're running to the store, maybe they could bring a few items home from the grocery store, because the last thing you want to do is take your newborn out to the grocery store or to Costco. If they come over and offer to help, have them throw a load of laundry in or fold a load of laundry. This is the time when you're going to utilize the community around you and utilize your support network. Postpartum emotional warning signs. If you are experiencing these warning signs, I want to encourage you to talk to your physician and your OB physician. And the reason I'm talking about them now is because mothers sometimes don't recognize these warning signs, but partners will remember this conversation, will remember this part of the training. So if you're having, in the first couple of weeks, it is completely normal for you to feel a little overwhelmed, to be physically exhausted because you're getting up several times during the night, to have some tearful moments. If that goes on past the first 3 to 4 weeks, then we're starting to become a little bit worried. If you're having trouble sleeping or sleeping too much past that first month, if there's changes in appetite, either too little or too much, feeling of exhaustion, feelings of being a bad mother, lack of interest in the baby, thoughts of harming yourself or the baby, you certainly want to get help. This is a chemical problem. We can fix it. There's lots of support for you in this process. We're going to be asking you some questions before you go home about how you're feeling that will help us identify those that are in a higher risk category. But we want you to pay attention to these warning signs. And again, you would contact your OB physician. And a little bit about breastfeeding. I'm sorry, my screen is covering up your words here, but it's important for you to get all the facts about breast milk. And in the 70s and 80s, a lot of talk was spent, a lot of money, a lot of advertising money was spent trying to convince you that breast milk and formula are equal. It is true that our babies will survive and thrive on formula, but breast milk and formula are not equal. There are properties in breast milk that cannot be recreated in formula. So if you are considering formula feeding because it just seems more convenient and they're equal anyway, I'm just here to tell you they're not equal. And it's been a big disservice that we have given to our moms in the past 30 years by trying to convince them that it is. Sometimes there are medical reasons why you cannot breastfeed. There are chemical reasons why you cannot breastfeed. As a lactation consultant, you have a ton of resources here in town. You will have a lactation visit whether you're breastfeeding or not, because we still want to tell you how to take care of your breasts. We're not going to come in and try to convince you otherwise, but we're here for education and support. And everyone will have a lactation consultant appointment before they leave the hospital. She'll come by your room and give you some resources. In those resources, you're going to find lots of places that you can go for continuing support once you've left the hospital, because we know that sometimes that's when you need the most support. But know this about breast milk. The Academy of Pediatrics recommends breastfeeding exclusively for the first 6 months of life, and then as long after that as both parties are in mutual agreement. So as long as you and the baby are still happy doing that, you can continue breastfeeding. After the first 6 months is when you will start introducing other foods. Breast milk provides all the nutrients that you need. You don't have to give any extra water, any other supplements. I like to talk about the benefits of breastfeeding. It's convenient, economical. It helps the uterus shrink down to its normal size. It encourages the release of oxytocin, which is your love hormone, which is going to help you bond with your baby. It reduces osteoporosis. You are less likely to develop breast, uterine, endometrial, and ovarian cancer. And for babies, it is the perfect food. It's perfectly matched nutrition. It can be protective against sudden infant death syndrome. We have less allergies. It reduces certain chronic diseases and infections. And baby receives skin to skin and eye to eye contact. Oh, and did I mention it's free and readily available? So here's what you need to know. This is your minimum breastfeeding 101. Again, we have an entire separate course that will cover breastfeeding in more in depth, but here's the basics. Your baby needs to feed a minimum of 8 times in 24 hours with no more than a 4-hour break. By the way, that goes for your bottle-fed baby as well. You never want to go more than 4 hours without a feeding. What goes in must come out. So how do you know your baby's getting enough? Well, we're going to be watching those diaper counts. In the first day, we want to see 1 wet diaper and 1 poopy diaper. Second day, we want to see 2 and 2. And it goes on like that until the first week, when we want to see at least 6 to 8 wet diapers in 24 hours. If we're not getting that output, then we are going to be concerned about the input. The other thing is we want to watch for those feeding cues. When you get into your hospital room, there's a little poster on the wall. Take pictures of it. That's the signs that your baby's going to give you when they're starting to think about wanting to eat. We want to get to them during those early feeding cues. Nobody wants to learn something or be patient when they're hangry. And so we want to get to these babies before they're crying. Crying is a late feeding cue. Colostrum is liquid gold. It's only small amounts that you need. It takes time to learn. You and your baby are going to learn each other, and it does take some time. It's not completely instinctual, and we are here to help you. Again, we're going to be coming in your room and giving you lots of resources and hands-on support. Here are those feeding cues that I mentioned. This is that poster. So when they're putting their hands in their mouth, opening their mouth, turning their head side to side, those are I'm hungry cues. Crying, agitated body movements, and turning red, those are your late feeding cues, and we missed it. So we got to get them calmed down before they're going to have an appropriate feed. Here's the volume of what your baby's tummy is. A newborn stomach is the size of a cherry. So only needs about a teaspoon of colostrum per feeding, and guess what? That's exactly what you have in your breast. We can help you hand express that and show you that you have that amount of milk, but the more times you put that baby skin to skin and put the baby up to the breast, the faster your more mature milk supply will come in. But we don't have to overfeed these babies. They only need a small amount in the beginning. So some tips that you might need for rooming in with your baby. All of our healthy babies stay in the rooms with their mothers. If there is a baby that needs additional medical support, we do have a NICU on site, and that would include a nurse, a NICU, a specially trained NICU nurse, as well as a neonatologist, which is a specially trained physician for neonates. So if your baby's in your room with you, you can always call us for help at any time. Sometimes when you move to the postpartum unit, you don't see the nurses as often, and that's because we don't need to be in the room as often. But it can feel a little lonely. So if you need help at any point, you can call. We never want to leave your baby unattended in your room. If there's some sort of emergency going on, maybe your baby is choking or something's happening, you would want to pull the emergency cord, which is located in the bathroom of every room. And when you go on your tour later tonight, you'll be able to see that emergency cord. You want to keep the bulb syringe, and we'll teach you how to use it within arm's reach, because sometimes these babies do have some extra fluid that needs to come out. And so a bulb syringe can actually help you help the baby. We recommend that you keep that within arm's reach. Even after you go home, it could save you a 911 call. We want to make sure that your baby is in the crib at all times when it's outside of your room. We don't walk around in the hallways with our babies. It's one of our infant security measures. You want to keep the baby close to your bed and furthest away from the door. You're not going to give your baby to anyone you do not know. There shouldn't be any reason that your baby needs to leave the room. If your baby needs to go somewhere, you or your partner are welcome to accompany your baby. And everybody should have picture ID name tag on their scrubs that you can see. And your birth educator in the room is going to show you what her name tag looks like. And now let's talk about your baby. All this effort, all this work that we've talked about up to this point, now we're going to move in and talk about your baby. So these are what our newborns look like when they're first born. So I'm just going to quickly show you some pictures so that you know that these are normal things. This vernix is a protective coating that is what keeps your baby waterproof on the inside. And it's kind of a cheesy-like substance that acts like a lotion. We don't have to wash it off. In fact, current evidence is telling us that one of the ways your baby gets the bacteria from your skin onto their skin is that vernix coating. So delaying the baby's bath or foregoing it altogether is evidence-based. And we will be delaying the baby's bath in order to make sure that your baby is getting all the good bacteria from that good skin-to-skin time. Molding of the head is very normal. In order for the baby to fit through the pelvis, sometimes we have some molding of this head. It goes away in just a couple of days. It's very normal, and it's nothing to be concerned about. Milia, those little white spots, these little pimple-like spots on your baby's skin, is normal. We don't have to pop them. They're just clogged skin ducts, and they will clear on their own. Your baby's hands and feet can be a little bit blue in color. That's actually normal. It's called acrocyanosis. We're not concerned if we have blue hands and feet. If your baby is blue around the lips or the mouth, that is not normal. That is an emergency light pull, or if you're at home, that's a 911 call. So again, hands and feet, it's okay to be blue. Around the lips and the mouth, not okay. Eyes are usually blue-gray. You'll know about what their color is much later, 3 months or more before we know for sure what color the eyes are going to be. Sometimes they can be crossed, that's okay, and they see about just 12 inches, which is exactly the length of space between holding your baby at the breast and your face. So that's a good way for your baby to do some bonding. Again, we're going to delay that cord clamping, and then it's going to be clamped and cut. We will put this clamp on that will be removed before you go home. We want to keep this cord clean and dry. We don't have to do anything special to it. You can fold the diaper down so that it's not rubbing up against it. Once you go home, you're going to continue watching for signs of infection, redness, oozing, excessive bleeding. If that were happening, you would want to go to your pediatrician right away. We're not going to immerse the baby in a bathtub until this has fallen off, and it'll be 10 to 21 days when this comes off. Eye ointment. This is an antibiotic ointment that goes into the eye. We prophylactically put it in all newborns' eyes to prevent eye infection. This is required by all 50 states. If you want to refuse this procedure, you'll need to talk to your pediatrician about it, and you will have to sign a consent saying that you would like to refuse. Vitamin K injection, also required by all 50 states. This assists the baby in blood clotting. So if there were any issues with the delivery where the baby needed some blood clotting factors, that vitamin K is not really up to par or at its full strength until about the 8th day of life. And so by giving babies vitamin K, we've been able to reduce the hemorrhagic disease of the newborn. We've eradicated it by utilizing this vitamin K. So it is an injection given in the thigh. Again, it's required, but if you want to refuse this, you would need to talk to your pediatrician and sign a refusal. The newborn screen is a screening test that looks for 70 different diseases that can be either controlled or maintained with diet or medication. So it's sent to the state. It's a very expensive test that you don't pay for. The state of California pays for, and it is required by all hospitals to do this on all newborns. So again, if you want to refuse, there would be a form that you would need to fill out. This blood sample will be sent to the state, and if there's something, if they detect one of these diseases, they will contact you at the address that you've given us when you registered. The other thing we're going to be doing is a hearing screen. We'll do a little test to see if the baby can hear. If the baby does not pass that screen, we will repeat the test in a couple of days, so you would be asked to return. And if the baby still does not pass that hearing screening, we would send you a referral to have that researched further. We're also doing a little congenital heart screening. It's non-invasive, O2 sats. We're monitoring the O2 sats. And again, we're able to detect quite a few diseases with both the hearing screen and congenital heart screen. And so we recommend highly that you let us do all of these processes before you go home. And then jaundice. I'm going to spend just a minute talking about jaundice, but here's the takeaway points. Jaundice is a fairly normal process. Your baby's liver is a little immature. And so as these excess red blood cells are being broken down, there's a byproduct being made that's called bilirubin. And that's what causes the yellowing of the skin. We want that bilirubin to get out of the body as quickly as possible. And the way your body gets it out is through stooling, having bowel movements. And the way your baby has lots of bowel movements is by eating. So increased feedings equal increased stool, which will equal decreased bilirubin. There are some medical conditions that can increase bilirubin, and your nurse will go over that with you if you have any of those medical conditions. Other things that can increase it is delayed initiation of breastfeeding or feedings, or even the process of induction. We have found some of the medications we utilize increase our chance of jaundice. So what we need to know is we want to get this bilirubin out of the body, and we're going to be testing your baby in a little non-invasive test in the forehead that is going to tell you what your jaundice risk category is before you go home. This is why it's so important for you to have a medical home to be able to take your baby to within the first day or so after delivery. Because if your baby meets the criteria to be in the high risk zone, you're going to need to be able to be seen by your pediatrician very shortly after you leave the hospital. So again, more will be talked about jaundice before you go home, but here's the takeaway points are feed, 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 no more than 4 hours in between feedings. If your baby's extremely sleepy and doesn't want to wake up for feedings, we can help you hand express your breast milk and cup feed or spoon feed. We do have some alternative methods. So warning signs for your baby. This is on page 52 of your book. Again, blue lips or color or difficulty breathing, 911 call. Eating poorly or refusing to eat. Your baby cannot go hours without a meal. They don't have the reserves that we do. So that is a medical emergency. If you have redness or drainage or a foul odor coming from the umbilical cord, that would be a reason to be seen at either the urgent care, your pediatrician's office the same day, or an emergency room. A fever of 100.4 or more, we only take their temperatures axillary. We don't do rectal temperatures any longer on newborns. And listlessness. If your baby has no tone and you just feel like your baby is listless, you certainly want to get your baby to the nearest hospital. And then we need to tell you, no matter how frustrated it might be, if your baby continues to cry or is extremely fussy, we never shake our babies. It's better to put them down and let them cry unattended while you calm down than to shake your baby. And another point I want to make here is make sure you know the coping mechanisms of your caregivers as well. Safe sleep environment. We want to make sure that your baby has all the possibilities of avoiding sudden infant death syndrome or SIDS. And one of those things we know is we want a nice firm mattress with no bumper pads or extra padding or stuffed animals in the bed. Babies need to sleep on their back. People, you shouldn't allow smokers around your baby. And if you are a smoker yourself, you want to change your clothing so that secondhand smoke, your baby is not breathing that in. And you don't want to dress your baby too warmly. So again, you'll be getting more information about safe sleep when you come into the hospital. I just want to mention these rules here. And we have reached the end of our presentation tonight. This is another time where you'll stop the video and have a question and answer period with your educator in the room. Here's our takeaway. This is what I want you to remember. Enjoy this journey. Not everybody gets to go on this journey, and I'm so thrilled that you get to be here and that you've chosen to come and have this journey with us. Each baby is unique. You need to trust your body. You need to trust the process, and you need to surrender to it. A good deal of how you nurture and love your child comes naturally. So trust your own parenting instincts, develop your own style, be patient with yourself and with your partner. Know that parenting is a process that requires you to constantly learn, and don't forget, most important, move, move, move in labor. Thank you so much for coming tonight. We're going to allow another bathroom break, and then we will get ready and go on your tour. If you have